how to diagnose a case of BPH. So as usual, for any diagnosis, we follow clinical feature and investigations, right? So regarding clinical feature, I've already explained. The patient may come to you with irritative LUTS, that is frequency urgency nocturia, or they may come to you with obstructive LUTS, or both. So whenever we get a patient with LUTS, we always evaluate a patient by IPSS scoring. We ask the question regarding those 7 symptoms and then grade the patient as a mild, moderate, or severe. We always try to identify whether the patient has any complication or not. How to know that? Hematuria, obviously, you can ask. UTI, if there's an UTI, the patient will present to you with fever and chills and rigor. Retention, yes, they can say, I'm unable to pass urine for last 2 or 3 hours. Whenever there is a complication, the treatment is surgery, not the medicine. Complication is an absolute indication for surgery. Okay? The most important thing that you have to do is DRE. DRE means digital rectal examination. So what we want to know? We want to know 2 things. One is we want to know about prostate, and we always want to know about the neurological status. So when you do a DRE, then feel the prostate. Okay. So while you feel the prostate, what are the things that we have to consider? First, size enlarged. So size enlargement is just a guessing thing. You have to guess, because by doing a lot of DRE, then you will be able to know the size. So enlarged or not, it takes time to understand. In BPH, it is enlarged. Okay. Surface is very smooth surface. And if you feel the prostate, then it felt like you're feeling your nose. Okay. So for reference, okay, if you feel your forehead, you can just feel your forehead, and that feeling is hard feeling, hard. If you feel your nose, that is what a firm feeling, firm, F-I-R-M, firm or elastic feeling. If you feel your lips, the feeling that you get is soft. Okay. Why we need to know that reference? Because we have to train our finger. A finger should be trained in such a way that if it feels something, it will understand, okay, this is hard, this is soft, this is elastic. So prostate is firm or elastic in BPH. Okay, firm, or you can say elastic in BPH. Hard in cancer, soft in abscess. Painless hard prostate indicate cancer prostate. Painless firm prostate indicate BPH. Non-tender, so it is not painful. So once you do a DRE, if you find these characteristics of prostate, it could be BPH. In neurological status, what do? We take a perianal sensation. That is, we check the sensation of anus. If the patient say, yes, I can feel it, then it is okay, right? Anal grip. We put a finger inside the anus and wait for a while. The sphincter of anus grips your finger. That is, the muscle tone is good. Okay, that means the nerve supply is okay. And bulbocavernous reflex, I've already explained. If you squeeze the glands penis of the male, there will be contraction at the anus. So this is motor component, reflex component. We are checking the component as 2, 3, 4. So this indicates the nerve is intact. If not, then you will get a finding, and you have to go through a detailed investigation to find any neurological problem. In case of BPH, we get normal neurological finding, okay, usually normal, and obviously we get a finding of BPH, that is enlarged, smooth, elastic, non-tender prostate. Obviously, if a patient comes to you with acute retention of urine, then you will see like this. Okay, so you can see a bladder is distended. A distended bladder is there, right? This is the abdomen wall, distended bladder. So how to know this is bladder? Number one, patient will come to you with a feature of acute retention. Okay, on palpation, you will have urge to pass urine. Okay, pass urine, because once you compress the bladder, patient will have urge to pass urine. The third one is if you percuss, it will be dull. Dull means just like percussing your forehead. So once you find all these criteria, this is distended bladder. Always examine the external genitalia and other part to identify any associated or any other differential diagnosis like phimosis, like stenosis of the meatus, and so on. So let me summarize. This is prostate, this is bladder. So whenever there is enlargement of prostate, it causes obstruction in the outflow of urine. It is bladder outflow obstruction. And whenever there is obstruction, it will present to you as symptoms like frequency, urgency, nocturia, known as storage symptoms or irritative symptoms, or intermittency, poor flow, straining, and sense of incomplete voiding. These are obstructive features or voiding features. They are known as LUTS, right? Also, patient may present to you with features of complications. The age group is around 50s and 60s years, male. Whenever we get these symptoms, what we do? We do digital rectal examination, and we have to examine prostate and identify whether it is enlarged or not. Okay. In the case of BPH, it is smooth, firm in consistency, like your nose, and it is non-tender. That is not painful. Always check about neurological status, anal tone, anal sensation, anal grip, and bulbocavernous reflex. So once we have idea fine, this could be an enlarged prostate, then what to do? We have to now investigate. How to investigate? There are some general investigations. We always do that. For example, urine routine and sometimes culture. Because you know, BPH is associated with obstruction. Obstruction is associated with stasis and it lead to UTI. Okay, there may be hematuria. So you can see those things in urine routine and culture. We do renal function test. In the case of prolonged BPH, it may cause reflux of urine, and reflux can cause bilateral hydronephrosis, and damage to kidney. We also check PSA. PSA is a prostate-specific antigen. Basically, it is done for prostate cancer. Okay. In BPH, it is usually normal, sometimes raised, but almost always normal. Even though we are suspecting a patient might have benign disease, we always check PSA. Whenever a patient has enlarged prostate, elderly patient, enlarged prostate, don't forget to do serum PSA. Now, then what are the investigations that is essential for diagnosing the BPH and also management? Those are ultrasonogram of KUB region and prostate with MCC and PVR, and Uroflowmetry. In routine and culture, rule out UTI and can see the hematuria. Creatinine electrolytes, these are the renal function tests we always do to evaluate the kidney function. PSA, normally it is within the normal range, 2.5 to 4 nanomole per liter, but maybe slightly increased in BPH. Uroflowmetry is an investigation where a patient urine passes through the machine. It will record the flow pattern in a graph. Normally, the graph is bell-shaped, where you can see the maximum flow is always more than 15 ml per second. It is usually 20 to 25, and the flow time, the time that the flow will be finished, is within 30 seconds. Okay, this is the parameter of normal flow. A patient will have a bell-shaped curve, finish the micturition within 30 seconds, and the flow rate, the maximum flow rate, which is measured as the height of this curve, is always more than 15, usually 20 to 25. In case of BPH, what we see is like the curve is not like bell-shaped. It is almost, the prolonged variety. You can see here the height, the maximum height it got is 10. So here the maximum flow, also known as Qmax is known as maximum flow, is here at this case it is 10. So it is less than 15. Less than 15 is abnormal, okay, is less. And see the time of the flow. This patient took around 71 second voiding time. This patient has taken around 71 second to complete the voiding. So this is a prolonged voiding. So a patient has the flow rate is less, and patient is taking a lot of time to pass urine. This indicate obstruction. Okay. So the Qmax, or maximum flow rate, if it is more than 15 ml per second, then it is regarded as normal. If it is less than 10 ml per second, then it is regarded as obstructed. Obstruction is there. And if it is between 10 to 15, then it is known as equivocal. So we cannot say concrete whether it's obstructed or not. So in the case of BPH, usually the Qmax is less, usually less than 15 or less than 10, and voiding time is prolonged. Prolonged means more than 30 seconds. So for a valid interpretation, the patient must pass more than 150 ml of urine. So first, always see this one. And the very important investigation is ultrasonogram of abdomen and pelvis. So you can very specifically say ultrasonogram KUB prostate with MCCPV. It is done through the abdomen, not transrectal. Transrectal ultrasonogram is basically for prostate cancer biopsy, and abdominal ultrasonogram is for BPH. Okay, so you can see K means kidney. Okay. We want to see the size of prostate. So size of prostate, normally in adult it is around 20 gram or 20 cc. If it is more than that, then it is enlarged. Okay. Echogenicity, that means the texture of the prostate, just to differentiate any suspicious mass. And we can see IPP. IPP means intravesical protrusion of prostate. That means if the prostate is too big, then some part of prostate may protrude inside the bladder. And if the protrusion is more than 10 to 15 mm, then it can obstruct the urine. MCC means maximum capacity of bladder before micturition. PVR means post-void residue. That means after micturating, how much urine is remaining inside the bladder. We can also see the bladder stone. BPH is one of the cause of stone formation in male. If there is a reflux of urine, then you can see hydronephrosis or hydroureteral nephrosis. You can see that, and always see the cortex thickness, so that you can guess whether that obstruction caused by BPH is damaging kidney or not. You can see that as well. Can give the size of enlarged prostate. Intravesical protrusion of prostate, that means this is bladder. Sometimes the prostate is so enlarged that it will go inside the bladder. This is known as intravesical protrusion of prostate. We can measure that by ultrasonogram, and if the protrusion is less than 5 mm, we say it is a grade 1 protrusion. 5 to 10 mm protrusion is known as grade 2. More than 10 or 15 mm is known as grade 3. more than 10 mm. Okay, so what's the importance of this? If the protrusion of prostate is more than 10 to 15 mm, then it is going to obstruct the bladder neck and can cause bladder outer obstruction. So we can also check the hydronephrosis, damage of upper tract or kidney. We can also see the complication associated with BPH like stone. We will measure the capacity of bladder before micturition, known as MCC, and then after micturition, okay, we will again measure the capacity of bladder. Normally, after micturition, there should not be any urine inside the bladder. But if there's a urine inside the bladder, it is known as PVR, that is post-void residue. If the PVR is more than 10 to 20% of MCC, for example, suppose the maximum capacity of bladder at that time was around 350 ml. That means if the PVR is more than 20%, means 70 ml, then we say significant. Significant means if this patient not treated, then this may cause reflux of urine. Okay, this may cause complication like UTI, reflux, and so on. If it is more than 100 ml, it is always significant and can cause complications. This is the ultrasonogram of KUB and prostate. You can see over here bladder. This is urine inside the bladder. This is the prostate. We can measure the length, breadth, and height, and we can identify the weight or volume of prostate. This is a lateral view you can see here. So this is the part of prostate that is inside the bladder. This is known as intravesical protrusion of prostate. If it is more than 10 to 15 mm, then it is a grade 3. So if you get a patient with LUTS and on DRD, if you find enlarged prostate, think about these two causes first. But sometimes you may not be able to appreciate the enlargement of prostate. You are not that much trained. Then you have to think these DD, that is the DD will be increased if you are not able to differentiate enlarged or not. In short, I can say these are the differential diagnosis of BPH. Serum pH is normal in BPH, usually normal, no doubt. Okay, this is correct. Post-void residual urine more than 20% of MCC is significant. Yes, the patient must pass at least 150 ml. Okay, less than 10 is obstruction. Okay, remember that. Stangury is the symptoms of bladder stone. Incontinence and hematuria is a symptom of complication of BPH. Complication, not an early sign. So frequency is early symptoms among these symptoms. Okay. Now see, let us see the treatment options. Treatment options are, we have watchful waiting. Watchful waiting means sometimes we don't give any medications, we just give advice, and the patient will be on our follow-up, and if required, then we will add medication later on. Okay, that is watchful waiting. Medical therapy means we'll use a medical therapy, that is drugs, to control the symptoms. And surgical therapy means we do surgery to treat BPH. Emergency management means patient of BPH may present to you with acute retention of urine. Then the first treatment that you have to do is put catheter, okay, and allow the urine to pass. Then after that, we do some other needful investigation and management accordingly. So let us discuss one by one. So watchful waiting. Watchful waiting is basically is appropriate for the patient having mild symptoms. We have used three criteria. One, the symptom score. Two, the uroflowmetry criteria, and three, ultrasonogram criteria. We haven't used the size of prostate. So size of prostate does not correlate with symptom. Sometimes a smaller prostate can cause severe symptoms, whereas sometimes even a large size prostate may not present to you with the severe symptoms. Watchful waiting means we'll wait, we don't give any medication. Rather, we advise lifestyle modifications and advise patient for regular follow-up, at least 6 monthly. Okay, see, we advise them not to drink a lot of water, especially when you are traveling, because if the person is in a travel, right, he may not be able to access the washroom or toilet. He will like wait for micturition, and if any BPH patient have a over distended bladder, it will lead to acute retention of urine. And why not to drink a lot of water at night? Because BPH is itself causing nocturia, and if a patient drinks a lot of water at night, it will increase the nocturia. He has to go to washroom multiple times at night because he will not be able to have a sound sleep. Consumption of alcohol and caffeine or coffee should be decreased or moderated, because these can act as a diuretics. That is, it increases the micturition. And we advise them to have a double voiding. The most culprit thing in this BPH is PVR, that is stasis of urine. So we always advise the patient to pass urine frequently, and if they go to washroom, then at least wait for a while to complete the micturition. Okay. And some patient complain of dribbling of urine. Nobody wants the urine to drop in the undergarment. So in that case, we say we hold the urethra and milk it out and squeeze all the drop of urine. Okay, that prevent post micturition dribbling. So if a patient don't have an indication of surgery but have severe to moderate symptoms, in that case we give some medical therapy. Then what are the drugs that we have? Basically, we have mainly two drugs. Okay, there are other drugs also. I'll explain it later on. Mainly two drugs. One is alpha-1 blocker and 5-alpha reductase blocker. What are those? See, this is prostate, and I have told you that the smooth muscles are more distributed along the peripheral part of the capsule and also along the periurethral area. Also, the smooth muscles are along these bladder neck. So these are the area where you will find the receptors, alpha receptors. Okay, receptors. Alpha receptors are the receptors for sympathetic nervous system. They are found in the smooth muscles. Okay, smooth muscles of the bladder neck, smooth muscles of the prostate, which are found along the capsule and periurethral area. So smooth muscles. Okay, in these smooth muscles we have alpha receptors. Okay, and alpha receptors, alpha-1 specifically, alpha-1 receptors. Okay, so alpha blockers, alpha-1 blockers, what does it do? It will act on these receptors and block the activity of smooth muscles. Okay, that means we can say it causes relaxation of the smooth muscle around the bladder neck and periurethral area. So when these areas is relaxed, the urine can easily go out. If the obstruction is caused by the contraction of the smooth muscles, then it is known as dynamic obstruction. Dynamic obstruction. By using alpha-1 blocker, we can relieve the dynamic obstruction of BPH. But there is also a mechanical obstruction, which is caused by a glandular enlargement. Okay, so if there's a glandular enlargement, it causes mechanical obstruction. You have to use 5-alpha reductase inhibitor. 5-alpha reductase inhibitor. Actually, it decreases the size of prostate gland. Okay, I'll explain the mechanism. Wait for a while. And sometimes we use a combined drug. The both drugs are combined and used. Let us see the name of the drug first. So, alpha blockers. Alpha-1 receptor are found in so many places, okay? Not only in the bladder, neck, or prostatic area, but also in blood vessels or smooth muscles of other area as well. We have two basic type of alpha blockers. One is non-selective. Non-selective means they can act in any place, alpha-1A, alpha-1B, alpha-1D. That means anywhere in the body, blood vessels, eye, prostate, bladder, neck, anywhere. Okay, they are non-selective. And the example are prazosin, terazosin, doxazosin. These three, okay, are the example of non-selective alpha blockers. Selective means specifically blocks the alpha receptor of bladder, neck, and prostate only. So alpha-1A is found in bladder, neck, and prostate. So if we have a drug which acts only in the alpha-1A, that means it will not have other side effect. Okay, that's why we have basically two drugs very commonly used is tamsulosin and silodosin. These drugs are selective alpha blockers known as alpha-1A blockers. Non-selective can block alpha-1A, alpha-1B, alpha-1D, everything. They can block all the alphas, alpha-1. Okay. The second group of drug was 5-alpha reductase inhibitor. This drug actually can decrease the size of prostate, and the example of this drug are finasteride and dutasteride. Now let us discuss each drug one by one. Okay. Alpha-1 antagonist or alpha-1 blockers. Okay, these are the receptor distributions. These are alpha-1A receptors. Okay, 1A, 1A. So alpha-1A is mainly found in smooth muscles of prostate and the bladder, neck. So whenever you use an alpha-1 blocker, if the effect that you want is smooth muscle relaxation at bladder, neck, and prostatic urethra. Right. So what does it do? Because relaxation, so it causes relief of dynamic obstruction. So dynamic obstruction is relieved, right? So that the symptoms will be improved very rapidly. This we want. This is our wanted effect. What about the unwanted effect? Unwanted effect, also known as side effect. It causes hypotension, orthostatic hypotension. That means patient will have a sudden drop of blood pressure when the patient stands from sitting posture, headache, dizziness, everything. Okay, this is due to alpha-1 blocking at blood vessel. It leads to hypotension. One more side effect is, see, this is prostate, this is ejaculatory duct, this is seminal vesicle, and this is vas seminal ejaculatory duct. When any male ejaculate, then the fluid from vas, the fluid from seminal vesicle, and the fluid from prostate get mixed over here and come out as semen during the sexual intercourse or ejaculation, right? But it will not go upward because there is a contraction of a bladder, neck muscle, such that it prevents the retrograde ejaculation. That is, it prevents the semen to go into the bladder. It prevents. But if you use a drug that is alpha-1 blockers, which relaxes the smooth muscle due to drug, part of his semen will go back into the bladder and part will come out. Okay, this is known as retrograde ejaculation, that is going towards the bladder, but there is no problem in sexual activity. So these are the complications of alpha blockers, alpha 1 blockers. That's why to prevent the complications like orthostatic hypotension, we give tamsulosin. They will reduce the incidence of hypotension, but retrograde ejaculation still persists. Alpha blocker shows its effect within few days. The maximum effect is shown within 1 month. That testosterone is converted to dihydrotestosterone by an enzyme known as 5-alpha reductase. And this converted dihydrotestosterone, it acts on prostate for prostatic growth. So if we can give a drug that prevent the conversion of testosterone to dihydrotestosterone, that means there will be less dihydrotestosterone acting on prostate, such that slowly the prostate size will decrease. That drug is 5-alpha reductase inhibitors. Example are finasteride and dutasteride. At least 6 months is required to have an effect, and within 1 year, 20 to 25% of prostate size decrease. That means, suppose a patient has 100 gram prostate, and if you have given this drug for around 1 year, 6 months to 1 year, then the size will be decreased by 20 to 25%. That means it will be around 75 to 80 gram. How it is possible? Because the lack of dihydrotestosterone in prostate will decrease the size of prostate, because DST is required for the prostate growth. Obviously, indication is patient must have moderate to severe disease, moderate to severe symptoms, and one more criteria: if the prostate size is less than 40 gram, then this drug will not act. Let me explain the adverse effect. Decreased libido means decreased interest to opposite sex. Decreased ejaculate means decreased semen volume. Impotence means you can say the patient cannot perform sexual act due to erectile dysfunction. When the testosterone is inhibited, is not converted to dihydrotestosterone by using 5-alpha reductase inhibitor, but this dihydrotestosterone not only act in prostate but also act in the external genitalia. You can say penis. Okay, so if a testosterone, that is dihydrotestosterone, is not there for prostate, that means it will be not there for penis also. And when the penis does not get adequate amount of dihydrotestosterone, it will lead to impotence. That is problem in having sexual activity. If the prostate size decreases, the prostatic fluid is also decreased, and that lead to decreased semen volume. Yes, a very good question. Rule 050. 5-alpha reductase, yes, it has effect on PSA value, no doubt, because PSA is secreted by the normal prostatic cell as well. If anyone is using 5-alpha reductase for more than a year, then the PSA value that you get should be doubled. Whenever you interpret a PSA value, always ask if the patient is using 5-alpha reductase or not. So there are some newer drug, we use that drug as well. Phosphodiesterase inhibitor. Phosphodiesterase inhibitor are drug basically used for erectile dysfunction. So sildenafil and tadalafil are the drug. These drugs can also be used in the case of BPH. Why? These drugs not only help in erection of penis by increasing the flow of blood into the penile area, but also it acts exactly as alpha 1 blocker. That is, it will relax the bladder neck muscle. It will relax the prostatic smooth muscle. So this is basically reserved for those patients who have erectile dysfunction as well as BPH. See, BPH start at the age of 50s and 60s, and erectile dysfunction also start at the age of 50s and 60s. If a patient is having erectile dysfunction and a problem of BPH, you can start with sildenafil or tadalafil. So it will work both way. Don't prescribe alpha blocker with tadalafil because it will cause severe hypotension. Okay, don't do that. Either you use tadalafil or you use alpha blocker like tamsulosin. Don't mix these two drugs. Whenever there is an obstruction by BPH, okay, the bladder muscle, that is detrusor muscle, also wants to overcome these obstruction. How? By contraction of muscle. These muscle will contract, and that lead to symptoms like frequency, urgency, and nocturia. So a patient of BPH, if he has severe irritative LUTS, then you have to add bladder muscle relaxant, either beta 3 agonist, and when the beta 3 receptors are activated, it causes relaxation of the bladder muscles. Muscarinic receptors are found in these smooth muscles of the bladder. So when these are blocked, these muscles will be relaxed. Okay, so we either use beta 3 agonist or anti-muscarinic drug to relax the bladder muscle. The anti-muscarinic drug or anticholinergic drug that we use are tolterodine and sulfenacin, and the beta 3 agonist that we use, just remember one example, mirabegron. So see, this is the summary of all the mechanism of action of the drug. Okay, let's see. Most commonly used drug is alpha receptor blocker. Okay, as you know, we have alpha 1A, alpha 1B, alpha 1D. There are so many alphas, but alpha 1A is mainly found around the bladder neck, and around the smooth muscles of prostate. Okay, so we use alpha blockers, especially alpha 1A blockers, to relax the bladder neck and smooth muscle of prostate. So these drugs are a first choice drug which relaxes this area and relieve the obstructive symptoms, especially dynamic obstruction. The second drug that we give is 5-alpha reductase inhibitor drug like finasteride and dutasteride. What does they do? They act on the glandular part of the prostate and they decrease the size of gland. How? By inhibiting the conversion of testosterone to dihydrotestosterone. And it takes time, at least 6 months to 1 year at least, to decrease the 20 to 25% of the prostate size. Okay, and there's another drug known as phosphodiesterase inhibitor, that is sildenafil, tadalafil. This drug have multiple action. It acts on the vessels supplying the penis and help to erect the penis. Also, it has similar activity acting on the smooth muscles of the bladder neck and the prostatic smooth muscles, just like alpha blockers, which can relax the muscle around the bladder neck and prostatic urethra, such that the patient will have early symptomatic relief. So we prescribe this drug to the patient who have both BPH and erectile dysfunction. Otherwise, we don't give this drug. Okay. And the last but not least, we have beta 3 receptor and M receptors in the bladder muscles. Okay, in upper part of the bladder, not at the neck. These area have these receptors. Patient who have irritative features like frequency, urgency, nocturia, along with BPH, if they are very much bothersome, with tamsulosin we can add either mirabegron, that is beta 3 agonist, or anti-muscarinic like sulfenacin, derifenacin, or tolterodine. We always start with alpha 1 blocker, specifically alpha 1A blocker, that is tablet tamsulosin. Okay, tamsulosin 0.4 milligram OD, daily at night. Then we see if the patient has prostate size more than 40 gram, okay, then you can add tablet finasteride. Same OD. So if the size is less than 40 gram, we don't add finasteride. We just give tamsulosin. If the patient has BPH and if he has erectile dysfunction as well, then we just replace alpha 1A blocker by phosphodiesterase inhibitor like tadalafil or sildenafil, like that. But don't mix alpha 1A blocker with this, otherwise it will cause severe hypertension. Don't do that. And if a patient with BPH, severe irritative symptoms, not mild, severe, in that case, obviously, we give tamsulosin, no doubt, tamsulosin plus minus finasteride. It is depending on the size. Plus, you can add other drug like mirabegron, or you can add solefenacin. Fastest action is done by alpha blockers, right? Finasteride is 5-alpha reductase inhibitor. Tetrastride is 5-alpha reductase inhibitor. Flutamide is for cancer prostate. We'll discuss later on prostate. This is alpha 1A blocker having a rapid onset of action. Finasteride is a drug. This is 5-alpha reductase inhibitor. So 5-alpha reductase inhibitor takes a lot of time to work, at least 6 months. Phosphodiesterase inhibitors, example, tadalafil, okay, sildenafil. Anticholinergic or antimuscarinic drug is solifenacin, tolterodine. Beta agonist is mirabegron, and the alpha antagonist are alpha 1A specific are silodosin and tamsulosin. These are specific. Non-specific are prazosin, doxazosin, terazosin. This statement is saying DHT is converted to testo, right? This is a false statement. Actually, what happened is testosterone is converted to dihydrotestosterone. So this statement is wrong. There are some absolute indication. That means we always have to do surgery whenever we get these conditions. Refractory retention of urine. And suppose a patient came to you with a feature of acute retention. What we do? We'll put a catheter inside, okay, and allow the urine to pass. At the same time, we add tamsulosin, and sometimes we may add antibiotics. Okay, so we start this management and ask the patient to come after 7 days. Okay, throughout the 7 days, he will have the catheter. After 7 days, we will remove the catheter, and after removing catheter, if the patient can pass urine, then continue medical therapy. Okay, and if the patient again develop acute retention, that is after removing catheter, patient was unable to pass urine. If this happens, then this is known as refractory retention of urine. Now you again put a catheter and plan for surgery. Recurrent retention of urine. Suppose a patient gave us history that he had acute retention at least 1 or 2 times before, okay, before acute retention, and again he came to you with another episode of acute retention of urine. Acute retention. So if a patient have a multiple acute retention of urine, then he's also a candidate for surgery. If BPH is obstructing the bladder, then it may lead a lot of complications like stone formation. Stone formation. Obviously bladder stone, okay, bladder stone, or recurrent UTI. If the patient have a history of UTI several times due to BPH, indication of surgery. If the patient has large diverticula. Diverticula is an outpouching of mucosa due to the continuous contraction of the detrusor muscle against the obstruction. The mucosa will outpouch. This is known as diverticula. If there is a bilateral hydroureteronephrosis, or we can say renal failure. If the patient has recurrent hematuria, these all are complications associated with BPH. If a patient come to you with BPH with any one of the complication, any one, okay, then we plan for surgery. There are some relative indications. For example, failed medical therapy, severe symptoms which is interfering his quality of life. Plus, if the patient has post-void residue more than 100, these candidates can be managed by medical therapy. But if the patient complains that he has a very severe symptoms, and if the patient wants surgical intervention, then you can do surgery in these patients as well. And remember one thing, only increase in size is not the indication for surgery. Suppose a patient has BPH, okay, and he has mild symptom, but the prostate size was around 45 gram. So here the prostate is fairly large. Here don't do surgery, no surgery, because the patient don't have any complications, no severe symptoms, no indication for surgery. Only the size is big, okay. But if the patient has severe symptoms plus minus complications, maybe complication, but the prostate size is just maybe 35 gram. It is possible sometime, okay. So this patient is a patient for surgery. That means size does not correlate to symptoms always. Now, what are the options that we have for surgery? The options we have are minimal invasive surgery, or open surgery. Okay. Minimal invasive surgery means we do transurethral surgery. Open means classical open. We cut the abdomen and go into the retropubic space and then do surgery and remove that enlarged BPH. Okay. So there are a lot of transurethral options we have. TURP means transurethral resection of prostate. This is the gold standard. Okay. Most commonly done surgery in the world. There are other options like TUIP, means transurethral incision of prostate. This is usually done for smaller prostate, small size prostate, small size. HOLEP. HOLEP means holmium laser enucleation of prostate. Here we use a laser to enucleate the prostate. Okay, there's a difference between resection and enucleation. I'll explain. Wait. We have transurethral vaporization of prostate. Here we use, in both cases, we use laser. holmium YAG laser is used. Okay. And we have options like TUMT, transurethral microwave therapy. This is basically done for patients who are unfit for surgeries. Okay. Opens, we have millions of Freyr's technique. We have two techniques: BPH with surgical indication that we have discussed, and then we will see the size. Okay, if the size is 30 cc or less, so the best treatment is TUIP, transurethral incision of prostate. If the size is between 30 to 80 gram or cc, then the options are TURP, transurethral resection of prostate. If it's slightly larger, like more than 50 and 60, we can go for HOLEP. HOLEP means holmium laser enucleation of prostate. The size is very big, like more than 80 or more than 100, then the option should be either open surgery, or if you can do HOLEP, then HOLEP is okay. HOLEP is better. You can do that. Or you can go for other laser option like TUVP, transurethral vaporization of prostate. Sometimes whenever the patient are not fit for surgery, suppose a male patient is around 70, 72 years, having a lot of other comorbidities like cardiovascular disease, patient is unable to pass urine, but you cannot do surgery. In that case, you can put catheter. Yes, why not? You can put catheter for longer duration, change it every month if you use transurethral, or we can do suprapubic catheter. What else we can do? We can use a technique known as TUMT, that is, we'll put a microwave catheter inside the prostate, and these will produce microwaves that can damage the prostatic gland, enlarged prostatic gland around the catheter, and after that it will necrosed and fall off. Okay, allowing the urine to go through it. Sometimes we can put a stent, or we can lift the prostatic lobe such that you can make a space out of it. All are the indications of surgery. All are indications, but I have asked you absolute indications. Absolute indications are bilateral hydronephrosis and recurrent UTI. Failed medical therapy and severe symptoms interfering with life, these A and D are relative indication, relative. Okay, whereas B and C are absolute. So while the size is not an indication for surgery. Yes, you guys are correct. Failed medical management means it's a surgical option is there. Size is 100 gram, it is more than 80, right? Whenever there is more than 80, you have two options. Either go for holmium laser therapy or any laser therapy, or open surgery. Here the option is holmium laser enucleation. The most common operative surgery that we do is TURP. This is usually indicated for moderately enlarged prostate, like size more than 30 gram, and obviously the patient must have the absolute indications or relative indications for surgery. Okay, before that, let me let me show the video first. Okay, you see, obviously we will use a dissectoscope, just like TURBT. This elevated structure that you can see here, this one, at the floor, you can see that elevated structure that you can see is verumontanum or veru, and right upper and left upper enlarged part is lateral lobe of prostate. Okay. This is veru. that elevated part. Yeah, this is verumontanum. This is our landmark for surgery. Distal to veru we don't go. Okay, and this is the prostatic urethra. Two lobes are so close to each other. Sometimes we say kissing lobes. Okay, you can see the lateral lobes are very enlarged. Posterior part of prostatic urethra. See, even the median lobe is also enlarged. So once you go inside the bladder, we always check for ureteric orifices, right and left. Yeah, this is the right ureteric orifice. This is left ureteric orifice. Again, showing you the two lobes. This is verumontana. Yeah, this is the loop. Now we are going to dissect the prostatic chips, the prostatic part. Here we are cutting the medial lobe first, slightly to make this space out. Okay. See, yes, see, this is what dissection means. Okay. These are arterial bleed. Arterial bleed have a jet flow, and once we see the bleeding, we have to coagulate the bleeding site. Normally, we use monopolar current, and in monopolar current, the irrigating fluid that we use are always 1.5% glycine. We don't use normal saline whenever we use monopolar current, because in monopolar current, if you use normal saline, then it will cause the spraying of electricity, and it will not causes effective cutting of the prostate. That control of cutting and coagulation can be done by a paddle. There's a paddle at our leg. We have two controlling paddle. So here the median lobe was removed. So see, if the median lobe is too enlarged, you can start with median lobe, or if not, then you can start with the lateral lobes at 5 o'clock or 7 o'clock position. You can start from that, and you have to resect the prostate around 360 degree throughout the prostatic gland. Okay, see. So the principle is resect the lobe, see the bleeding site, stop the bleeding, and again resect. So resect, stop the bleeding, and resect. This will be the sequence. Okay. Now we are resecting the 7 o'clock position, lateral lobe, right lateral lobe, resecting it, and checking for the bleeding site. If you see any bleeding site, we just coagulate it. This is verumontanum. See, it is still intact. So we always check verumontanum time to time. So these resected pieces are pushed back into the bladder, and later on it is removed by using ilex evacuator. Okay, we can remove that. Later on, see, this is ilex evacuator. We are evacuating those chips of prostate, and then later on, once the surgery is completed, we will send these chips to the lab, okay, for histopathology. Yeah. So now see this view. Whenever we see this view, that is the black hole is seen, it indicates that the adequate resection is done. So once we finish the surgical procedure, we put the tri-channel catheter, okay, and we distend the balloon at least using 30 ml of distilled water, and we put a traction, slightly pull it down such that it prevents the bleeding from the bladder neck. The tri-channel catheter is used for irrigation. Cutting is done by the diathermic current. There are two types of diathermic current. One is monopolar, other is bipolar. If you use a monopolar, which is very common, the normal irrigation slide fluid we use is 1.5% glycine. I have already explained that. And in bipolar TURP, you can use both, but normal saline is preferred in bipolar. Let me ask you one question. After TURP, can any patient develop cancer prostate in future? Okay, answer is yes, he can. See the picture is explaining that in TURP we just remove the transitional zone, enlarged glands. Still, the peripheral zone is intact. Cancer prostate arise from peripheral zone. Okay. In TUIP, so when you resect the at 5 and 7 o'clock positions, then you will open the prostatic tissue. Okay, so that the urine can easily pass through it. So as the size was less than 30 cc, so there was not enough prostatic tissue. So we have just resected the 5 o'clock or 7 o'clock position, and this is known as TUIP. FOLEP is a laser technique. So what we do is we go through the urethra, obviously, transurethral. Then we start by using a laser therapy. We start to, just make an incisions or cut the prostate tissue around these enlarged lobes. Okay, peel the gland from the prostate and send it to the bladder. And after that, we use a cutting instrument and we cut into pieces and bring it outside. See, resection means, you have seen the video, resection means uh, cutting the prostate as a, as just like you are scooping the ice cream. Okay, but here enucleation means we have just peeled off this enlarged gland, not resecting it, just remove it, peeled off from the prostatic tissue, and then later on, cut into pieces by other instruments and bring it out. So holmium laser has a advantage because it can enucleate larger glands. So what are the complications of TURP? This is very commonly done surgery. Let us discuss about this first. See, wait. So the early complication means complication during surgery or just after surgery. The very common complication in early stage is hemorrhage. As you have seen in the video, once we cut the prostate, it bleeds because prostate is a highly vascular organ, right? If the bleeding occurs within the surgery, during surgery, then this is known as primary hemorrhage. And if the bleeding occurs within 24 hours of surgery, then this is known as reactionary hemorrhage. Okay, there are some surgeries which are very notorious for reactionary hemorrhage, like TURP, thyroid surgery, tonsillectomy, and hemorrhoidectomy. Always watch for bleeding within 24 hours. For TURP, what we do is we put a traction in catheter to prevent the bladder neck bleeding, and also we irrigate the bladder continuously such that even there is a bleeding, it will not clot the bladder. If you resect deeper and very deep, then you may perforate the capsule of prostate. This is also possible. And there is a syndrome known as TUR syndrome. I'll explain. Wait for that. Late complications. One of the very common complication is retrograde ejaculation. See this picture. So what you have done is you have removed the chunk of muscles around the bladder neck, right? So whenever there is ejaculation, then these bladder neck will not contract effectively and can cause retrograde ejaculation. Impotence means, due to that, see, you have seen we have dissected the prostate by using current, right? That monopolar or bipolar current. So that can cause damage of a neurovascular bundle which lies just posterior lateral to prostate. Okay, there is a penile nerve, the nerve that supplies the penis. Okay, vessels supplying the penis lies around the posterior lateral part of the prostate. So if they are injured by thermal injury, then that can cause impotency. If you injure the external sphincter, okay, then that can cause incontinence. As you have to introduce big instrument inside the urethra to resect these tumors, these BPH, there is a chance of stricture urethra. Any surgical procedure can lead to infection, and sometimes surgeon does not remove adequate prostatic size, so patient may come to you after 3, 4, 5 years for reoperations. TUR syndrome. TUR syndrome means transurethral resection syndrome. When you do TURP, what you are doing is you open the venous sinus. So obviously, when you resect the prostate, some venous sinus will open, right? And as you are using the irrigating fluid, I'm talking about monopolar, okay? Monopolar. Very commonly used technique is monopolar. The irrigating fluid that we use is 1.5% glycine. So see here, when you use this irrigating fluid, this fluid will go inside the blood vessel. The glycine is metabolized such that only free water is left. The glycine is utilized by liver, metabolized by liver, whereas the free water remains inside the blood. And you know, free water means what does it do? It will dilute the blood. And once it dilutes the blood, it causes hyponatremia. Hyponatremia. That is, the sodium level will fall down. As it is caused by dilution of blood, we say dilutional hyponatremia. In short, we can say water intoxication. What about the glycine? The glycine is metabolized and it forms ammonia. Okay, now you can see here, these, due to the lack of sodium, it causes some cardiovascular impact or neurological features. And excess amount of ammonia can also cause neurological symptoms. So you can see a patient who underwent TURP can develop some cardiovascular symptoms and neurological symptoms due to dilutional hyponatremia and excessive ammonia accumulation inside the body. This is common in the patient where size of prostate more than 45 gram, and if you took more than 90-minute time, in this criteria, in this situation, there is a chance of these problems. So whenever you resect for longer duration, more amount of fluid go inside the blood and can cause these problems. And the clinical features, obviously, nausea, vomiting, confusion, all those neurological features, hypertension, cardiovascular problem, bradycardia, and visual disturbances. So these are the clinical features of neurological and cardiovascular impact. And treatment, as you know, the main mechanism behind is excess amount of water. So start furosemide. Furosemide is a diuretics, such that it will remove excess amount of water. But sometimes, if hyponatremia persists, if it is severe, if the sodium level is less than 120, then start 3% NaCl. Basically, large prostate size more than 80 to 100 gram, then you can go for open prostatectomy. But still, you can go for HOLEP, but you can choose between these two. And if a patient has a double pathology, a BPH with bladder stone, then you can just do open surgery for both at the same setting. This is a Million's prostatectomy. Here, what you have done is we open the abdomen. See, open the abdomen, went through the retropubic space known as space of Regius, and we cut the prostatic capsule. Once you cut the fibrous capsule or prostator capsule, we introduce our finger and enucleate around this zone, around this space, and remove the gland intact. Okay, and then we stitch the prostate. So this is still the peripheral zone is left. Even you do open surgery, the peripheral zone is still left. So this is Million's prostatectomy, also known as retropubic prostatectomy. So transurethral technique means through urethra. Okay, that is TURP, HOLEP, TUIP, all are done through the urethra. This is transurethral, minimal invasive technique. And if you go through the retropubic space between the symphysis, pubis, and bladder, retropubic space, then this is known as Million's prostatectomy, also known as retropubic prostatectomy. If you go through the bladder, open the abdomen, cut the bladder, and go inside the bladder, and from the interior of the bladder, if you do a surgery, this is known as Frere's technique. Okay, and if you go through the perineum, then it's known as Young's technique, which is not done nowadays. Even after doing TURP or even after doing open surgery, there's always a chance of getting cancer prostate from peripheral zone. Don't forget this thing. Okay. The most common complication of transurethral recession of prostate is in this option, retrograde. I've told you 75% of cases will develop retrograde ejaculation. Patient underwent transurethral resection of prostate, and within 1 hour he developed vomiting and altered sensorium. Altered sensorium means neurological impact. Water intoxication, you can say, or you can say TUR syndrome, same thing. Okay. A delirium, mental confusion, nausea in the patient underwent TURP is basically TUR syndrome. So whenever we get this type of scenario, then we have two differential diagnoses, BPH and cancer prostate. Okay. Investigation that you do now, uterine culture, normal. For this case, RFT is normal. For this case, ultrasonogram of a KOB and prostate region is showing you enlarged prostate is there with some protrusion inside the bladder. Okay. PSA was also normal. IPSS scoring was done, it was 19. Okay, see the prostate size. So you got all the parameters that we need. Size was 50 cc, PVR is 110, IPP is 12. Normally it should be less than 30, it is now 40, and flow rate usually should be more than 15. Here it is 12. So IPSS score is also 19. What is my diagnosis now? So BPH with moderate symptoms, and there is no other complications. Okay. Then how will you manage this case? BPH with moderate symptoms, we go for medical management. We start with tamsulosin, and as the size is more than 40 gram, we have to start finasteride. Okay, combined, and follow up. 58 years old male presented to you with sudden inability to pass urine for last 2 hours. He is having problem for last 2 years, and for last 2 hours he had acute retention of urine. DRE shows enlarged prostate. So it's a very clean-cut case of acute retention due to BPH, because he is a known case of BPH. We know that. What is the immediate management? So my immediate management should be catheterization. Put a catheter through urethra. If not possible, then do SPC. SPC means suprapubic catheter. Then always do urine routine and culture. Here I have seen plenty of pus cell indicating there could be infection. This increased PSA value may be due to infection. So in the case of BPH, the PSA may be increased if it is associated with infection. See, the prostate size is 60 cc, IPP is also fine. Uroflowmetry could not be done because we have put a catheter. So after putting a catheter, we can't do uroflowmetry. My diagnosis is acute retention of urine due to BPH. Okay, how will you manage this case? So I'll start tamsulosin for 7 days and put antibiotic. Okay, because he's having multiple pus cells for 7 days, and call the patient after 7 days, and I'll remove the catheter and allow the patient to pass urine. If he can pass urine, then I'll continue the medical therapy, and I'll add finasteride because size was more than 40. It is 60. But if it is unable to pass urine, then I'll recatheter and I'll plan for surgery. That is TURP. So this is the way how we manage a case of acute retention of urine due to BPH.